welcome everybody. I am really excited about this meeting. We have a wonderful speaker today, but before I introduce our speaker, I want to show you a short video from my amazing trip to Hawaii. We got back last night, and we did something that I had never even heard of before we went this week, which was snorkeling at night for manta rays. And so we're going to show this video, and I'm going to explain it real quickly. You go out at night and they shine ultraviolet light in the water, and then you see the manta rays come up, and they're 9 to 11 feet wide, their wingspan, and they come up and they swim and they do somersaults and they do all kinds of things. So we're going to have to stop the screen sharing, Ashlyn, and then we will show the, now I will share my screen. So it looks like something out of Star Wars, and it is really cool. And they know which, they all have names. There's like 300 of them, and they know which one is which. And this one has a name, I forget what it was. I know it because it has broken skin. So. Okay, we can stop my screen. So do you like that? Was that cool? That was the coolest thing I have ever done. I will never do it again, but it was, you go out and we were hanging onto a surfboard with ultraviolet lights shining down, and they came up and they brushed up against us. They do these somersaults. It was so cool. Anyway, back to the program. So our speaker, Patricia Miller, is, she started her career at Cedars-Sinai Medical Center in 2006 before joining the Tech School of Medicine at USC in 2015. And at USC, she specialized in medically complex patients, specifically neurogenic dysphagia and communication disorders, and dysphagia and the tracheostomy and vent population. She's a native of Southern California. She saw a need in our community for improved access to quality care and comprehensive speech services for the adult population, and founded her company, SoCal Speech Therapy and Swallowing Diagnostics, in 2020 to do just that. She received her Bachelor of Arts in UCLA and her Master's in Communication Disorders from Cal State LA, and holds a certificate in clinical competence with the American Speech, Language, and Hearing Association. So with that, I'm going to welcome Patricia, and take it away. It's all yours.
Thank you so much, Sharon, and good morning to everyone. I feel so excited and honored to be speaking to your group. And before I jump into everything, and obviously I think this is an extremely important topic, I want to thank Sharon for what she does, for bringing us all together. It's a really big deal. We talked briefly before we started about how she was kind of the only one out there blogging. I feel like a certain kindred spirit with that, because there aren't too many people talking about speech needs or swallowing needs in the setting of Parkinson's. So a big thank you to Sharon, and to all of you. Hopefully you all feel comfortable. You can stop me at any time in the presentation and say, hey, you know what? I'm thinking of something right now. I have no problem answering any questions that may come up. We obviously have a designated spot at the end, but if anything comes up while you see a slide, I have no problem stopping. So I'm going to jump right in. Our agenda today, I am going to talk about the changes in swallowing specifically, and in speech in people with Parkinson's, those implications, and talking a lot about awareness, advocacy for oneself, and how to obtain a referral for speech therapy. Next. So we all know about I'm going to minimize this a little bit. We all know about the pharmacological management of symptoms. Most people here are under the care of a general practitioner, a neurologist, even better, a motor disorder specialist. And the pharmacological management is typically managed with the dopamine agonist medications that many of you are probably familiar with, the Mirapex, Requip, Nupro, Cinemets. And let's go to the next one. And the therapeutic management. So we talk a lot about PT, physical therapy, a lot about occupational therapy. Speech therapy sometimes gets missed through the cracks here. And obviously I'm a bit biased because I am a speech therapist, but we have to do with communication and swallowing. And those are huge parts of being a human being. And just a quick question out there. Has anyone out this morning out in the group worked with a speech therapist before? I don't know if anyone has.
I'm working with one currently.
Okay, wonderful. And how many of you out there know that speech therapists actually also deal with swallowing issues? That might be news to some of you out there, or the ones that are already linked in with a speech therapist know that. But when swallowing issues come up, this is the therapist, this is the discipline that is working on that, okay? We'll go to the next slide. So the more we learn about Parkinson's, the more complementary medicine is being embraced. And I see the gamut, okay? I started my career in 2006 at Cedars-Sinai, like Sharon said in my intro. I see the gamut of physicians who've been trained and who embrace different type of modalities to help with symptoms. So yoga, massage, acupuncture, art therapy, music therapy, boxing, those things are obviously complementary and can be very helpful. We'll go to the next one. But today, I wanted to be really focused to be able to cram in as much as I could, even though this is a pretty big topic, but we're going to talk about the 3 Ds. And I really felt like if I attended this, I want to take away the language that I can talk to my physician with and kind of say, yes, okay, we're on the same page. I'm experiencing this. And that when you hear words being thrown around, you go, oh, okay, I know what that is. So dysphagia is the medical term that we use for trouble swallowing. Dysphonia is the impairment of the voice. So when the voice becomes weak, the voice can sometimes get very rough. It can kind of get like a different quality. It can become breathy. The pitch can change. That's the dysphonia. And dysarthria occurs when you hear more of that slurring. So if the tongue or the lips or the cheeks aren't moving as much, or there's any rigidity, that's going to result in a dysarthria. Okay, we'll go to the next slide. So the reason that I'm always aghast that we're not referred in the bundle of therapies is because approximately 90% of people with Parkinson's will develop speech and swallowing issues. This is out of York's in 2004. 90% of people with Parkinson's will develop dysarthria during the course of the disease, and voice abnormalities tend to be the first indication. Let's go to the next slide. So circling back to problems with swallowing. Swallowing is typically divided into 3 phases. And for the purpose of our chat this morning, I'm going to really focus on the oral and pharyngeal, oral or throat phase. Okay, the pharynx is the throat. So the oral and pharyngeal phase is really where I want to focus the attention of our chat. The 3rd phase is the esophageal phase. A lot of us know that with Parkinson's, there's a lot of GERD. There's been a lot of attention seeing GI specialists now when you're dealing with Parkinson's. But for our chat, I'm going to talk about the first 2. And let's go on. So here you see a cross-sectional of someone obviously having a sip of water. So in the normal phase, the normal oral phase, your lips close, they form a seal. Chewing and mastication of food begins. The food is mixed with your saliva. It forms something called the bolus. That's our kind of lingo for that cohesive bit of food. And then that bolus is transferred to the back of the mouth. And that's when the brain takes over. And that's a reflexive motion. And the trigger happens, the swallow. Let's go to the next slide. But when there are changes in this phase, it's going to affect everything, right? So if there's poor lingual control, okay, that can happen. Later on in the disease, sometimes we see something called fasciculations, a little bit more of like a tremor of the tongue. There can be difficulty chewing foods, solid foods. And 78% of people with Parkinson's notice an increase in saliva, and they always say, oh, there's an increase in saliva, there's an increase in saliva. And it's actually not really an increase. It's actually that the habitual reflexive act of swallowing isn't occurring as often. So all of us have swallowed many times. I've swallowed many times since starting the presentation. But if I don't swallow, of course, I'm going to accumulate a lot of saliva. And one of the things that I tell patients when they come to me with this complaint, I start with very basic, simple modifications. Like, can we, put like a reminder out, like on your, watch. If you don't want to do anything like that, like a sugar-free piece of hard candy, so you have that sensory input to swallow, or even chewing some gum. A little more of an invasive measure, some neurologists will like inject Xeamine to kind of dry that up, but I never recommend that as the first step. And if you have trouble with the oral phase, that can affect the next phase, okay, which is the pharyngeal or throat phase. And we'll go to the next slide. Here you see a cross-sectional of someone's mouth. You also see the spine and the esophagus, and that kind of, let's see if can you guys see my cursor? I'm circling the trachea, so I'm not really sure if my cursor can be seen. So some changes in the throat with Parkinson's that you may not experience. I don't want anyone to think that what I'm saying is, oh gosh, this may happen. You may feel this, you may feel one of these symptoms, you may feel all of them. So it is a continuum depending on where you are and how you feel. So sometimes there's a sensation of food feeling, stuck in the throat, or residue feeling stuck in the throat. And the biggest thing we want to prevent is aspiration, material from entering the airway. The most real dangerous, if we can use that word, is silent aspiration, where somebody looks perfectly fine and they actually are getting material and food into their airway. And the only way we know that is really with diagnostic imaging. And there would be signs, though, of somebody having difficulty, even if they're silently aspirating. Usually they would be spiking a temperature. They would have like a general malaise. They could have some pain, when they're breathing. And usually when you go and you call your doctor and you explain these symptoms, they would want you to get a chest x-ray done. But I would recommend that if you're having any trouble swallowing and it's happening on a regular basis, excuse me, this is very funny that I'm having trouble swallowing when I'm talking about that. Okay. I would recommend that you call your doctor and you ask for the modified barium swallow study. We do these all the time in the hospital. They're not invasive. You can get it done as an outpatient. You do have to go to the radiology suite. A speech therapist like myself would be doing it with the radiologist, kind of getting a sense of what your symptoms are, getting your background, and then they set up some food, and all the food's going to have a little bit of barium in it, and that's some contrast material that's going to look black on the screen, some opaque contrast. And that's just so we can see where everything is going. Is it going into the airway, or is it going down the esophagus where it should be? The other big reason diagnostic imaging, the modified barium swallow study, is important when you have any trouble swallowing is because it gives your therapist a roadmap of how to treat you. I always tell people, if you break your leg and you go to PT, your PT probably has an x-ray of your break. So to get, to have a good speech therapist working with you, they would want diagnostic imaging to see where is the breakdown, where do you have residue. So let's go to the next slide, Ashlyn. And I'm going to show you here a video. I'm going to show it twice. Fine. So this is, as you can see in the back, that's the spine. And the black material is the barium, the liquid barium I was telling you about. So this is allowing us to see if this material goes down the esophagus or if this material enters the airway. So what I had embedded, unfortunately, and like, we're just going to go with the flow, because the important part is that you understand the information, that you know the terminology. What this video shows is that the material is entering this person's airway. Okay. The video also shows where the food is kind of getting stuck. So as a speech therapist, this is very invaluable, because we could possibly modify the diet to something safer. We could come up with some compensatory strategies, some recommendations, but really, and this is also very important, we know what to treat. We say, hey, this is why it's weak. We know that the base of your tongue is weak. That's why you have a lot of residue here, or you don't have a lot of elevation. Is something natural that happens when we swallow. The whole throat, the whole larynx elevates. So the imaging is quite important if you're experiencing any trouble swallowing. We'll go to the next one. And what I can also do, if anyone wants to see that, I can also email Ashlyn and Sharon a link, and maybe she can like put that up so you can see a video of someone actually aspirating. So some of the signs are coughing and throat clearing with meals, drinking or eating, having that difficulty, maybe choking on saliva, feeling like food is stuck. Sometimes esophageal issues result in like a referred globus sensation. So if you have like an esophageal issue, you can also feel like food is stuck. And also if someone's losing a lot of weight, that's also something that should be kind of a red flag, what's going on. But anytime you're experiencing pain, okay, please seek medical attention if you're experiencing pain when you swallow. Let's go to the next slide. These are general precautions. These are obviously very basic, but they're important to really try to sit upright. And if you're physically able to sit at the table, I include this whenever I talk about this, because people sometimes eat reclined. Like they'll tell me, oh, I actually like watching a show and I sit on the couch, or I sit on a reclined, chair. And so really, if you can kind of help the position, that's half the battle. It really increases the chances of aspiration when we're reclined. Reducing distractions. Again, these are very simple. And I know this, we all know this, but we tend to be social. And if we have the luxury of sharing our home with others, we tend to eat meals with them. So that's important to kind of, if you're already having trouble, say, okay, I'm actually not going to engage in a conversation right now because I have to be very careful when I'm chewing, when I'm swallowing. And also the timing of meals and medication is important. So let's go on to the next slide. So we're going to talk now about changes in speech. We kind of covered swallowing, a very condensed overview of swallowing. Now we're going to move on to speech. Next slide, please. I see that questions are popping in. Is it all right if I address those when we're done? Or is that okay?
Whatever, yeah, that's fine.
Okay, this is interesting. When this was created, the N was obviously at the end of these words. So the top. So the changes that occur in speech in the setting of Parkinson's is because there are changes in the way you're breathing. And that image that you have on the top right of your screen, that's your throat. And those are your vocal cords. So your vocal cords are those two little white kind of bands that look like the shape of a V. They open and close when you breathe. They also vibrate, come together for voicing. And deep down in that kind of tube, that's your trachea. So obviously we don't want any food going down there, but the changes in speech occur when you have all three of these change. The respiration, the coordination, the speech breath coordination is changed, the phonation, and the articulation, the mouth, the tongue, the lips. Let's go to the next one. So the two Ds here, dysarthria and dysphonia. This was in the Journal of Clinical Neuroscience in 2020. Emerging evidence suggests that voice dysfunction is the earliest sign of motor impairment in Parkinson's, and the complexity and fine motor control involved in vocalization may result in dysfunction here before the limbs. And I think that's very interesting. And I just wanted to share something with you. The founder of the Parkinson's Voice Project, which I'm going to touch upon a bit later, she created Speak Out Therapy, which is wonderful, a really great treatment protocol. She gave this example about somebody who has Parkinson's, who might be having some gait issues, balance issues, and not navigating a curb, falling, getting bruised up. Immediately, everybody says, okay, you got to get into PT, right? We see that bruise, we see that danger there. People's voices change, they get softer, they might drop out of conversations. No one's really sounding the alarm, right? So it's just a very interesting thing that if we're going to talk about treating people holistically and the whole person, of course, like I said at the top of this, I am a speech therapist, so I definitely want to be in the conversation because it's very important. So let's go to the next slide. So dysphonia is something, the characteristics are reduced vocal volume. So you have it's a lot softer, and it can be change. It can get very hoarse. It can get breathy. There could be instability of the voice, right? So that's more of a tremulous voice. And let's go to the next slide. And dysarthria. So if your jaw and your tongue and your lips are a bit rigid, you aren't going to be able to produce those sounds the way you did, right? So dysarthria also incorporates the breath, not being able to have enough breath control to get my sentence out. So I might be pushing it out like that. It can become monotone and monopitch. So we have the monotone, monopitch. We also have less facial expressions. When we speak, there's a lot of melody in that voice, right? And we call that prosody. So this is something that can happen as well. And a lot of times difficulty initiating the voice is something that a lot of my patients tell me. Sometimes I just can't even initiate it, okay? The rate can be bursts of speech very fast and kind of slurred and very fast. It can also vary. And the most common dysarthria with Parkinson's is what we call hypokinetic dysarthria. Let's go to the next slide. Okay, so this is one of my favorite parts. So I kind of pulled a couple, not a couple, I think I pulled like 4 or 5. I think I pulled 4 or 5 questions of an index of a questionnaire I asked people to kind of bring the awareness. And one of the things that I think is very important, and I do want to talk about briefly, is that when people come and get an evaluation, sometimes they say, oh, my husband, my daughter told me to come here. And I'll say, oh, okay, how come? Oh, because she said that she can't hear me when she calls me. So one of the things, and it's neurological, it's not because someone's being stubborn, it's because there is a decrease in self-awareness, right? That's the basal ganglia. There's a decrease in self-awareness of how loud you sound, or that you're walking differently, or that your handwriting has changed. So if you can go to the next slide, Ashlyn, please. These are some of the questions I ask. Does your voice make it difficult for people to hear you? Do people have difficulty hearing you in a noisy room? Does it restrict your personal or social life? Do you ever feel left out of conversations because of your voice? This is a big one. I have a bi-coastal woman who has to attend many events, and she said no to most of them. And this is the one that she said, yes, this one. I feel as though I have to strain to produce voice. She said that by 3, 4 o'clock, if she had been talking and going to her events, and by 3, 4 o'clock, she was puttered out. So when her daughter called her, she really her voice was shot, and she just had a lot of vocal fatigue. And the last one I ask is, has anyone asked you what's wrong with your voice? So these are important things to kind of bring that awareness back. Let's go to the next slide. So the reason this is very near and dear to my heart, and I can't thank Sharon enough for letting me speak to you, because I have been in this profession since 2006, and my colleagues are PTs and OTs, and I see the value in all of our areas, right? But I had a patient, she came to me and she was probably Hone-Yar scale 5. And if you all remember the continuum of Parkinson's, Hone-Yar scale 5 is the last stage. She was in a wheelchair. She needed assistance for all of her activities of daily living. And she recently passed, and her husband said that out of all the things that started changing, the biggest thing was that, you know, they needed to still hear her. They wanted to still talk to her. They knew that she would want to talk to them. So, you know, we all need speech and communication on a very basic level. Most of us need it to maintain our employment. We all need it to maintain social contacts. There's so much identity in our voices. Sharon lost her voice, I think, like 2 weeks ago when we were connecting. She's like, I lost my voice. I'll talk to you later. I have to catch up with you later. And imagine if that just slowly starts happening. But we know this, like we know this is something that happens with Parkinson's. So this is why I'm kind of trying to scream from the rooftops, like, get speech. So not being able to use your voice being extremely soft, people not being able to hear you, that impedes your ability to, you know, do all these things, access healthcare and communicate with your team. Let's go to the next slide. So speech disorders in Parkinson's disease can obviously lead to decrease in participation. I'm obviously speaking to a group this morning that's very motivated, and Sharon's created this space for us to have this community. But when you have repeated experiences that aren't great, right? Fewer and fewer positive exchanges because like people can't hear you or they don't understand you. And then sometimes people kind of stop asking you what your opinion is, or you kind of self drop out because it's hard. And that can obviously lead to social isolation, your ability to communicate with your family and friends and your community, and obviously loneliness. So let's go to the other slide. So that's really what I'm trying to say, that time is of the essence. We know this is something that is part of this disease. And there are people like myself out there who have the access to be trained in therapeutic programs. Let's go to the next slide. So this is the one I'm going to talk about today. So this is actually, we're kind of turning the page back into positivity. So Speak Out therapy is something that was created by the Parkinson's Voice Project, and they're based in Richardson, Texas. I was initially certified in Lee Silverman voice treatment, and some of you out there may know that program as well. Now, I became certified in Speak Out, and so I can kind of judge both programs, and I love this program. I love this program because it's six steps every time you do it. It's really easy to get into, and the treatment involves education, individual speech therapy, and then once you graduate from your individual speech therapy, you do group sessions called the Loud Crowd. Those can be done online as well. Let's go to the next slide. So this program is based on the principles of the late Dr. Daniel Boone, who was a speech pathologist. And when he was getting his doctorate, he was in the Midwest and he was working with a group of patients who had Parkinson's. And he said that he asked them to do an automatic task, such as counting to 10. And they all had dysphonia. They all had very soft voices. They were monotone, monopitch. And he said that the crowd sounded like 1, 2, 3, 4. It was soft. It was hard to understand, like I said. And then he said, okay, well, let's do it backwards. And he said, when they did it backwards, they said 10, 9, 8. And so the whole idea of intention, which is really the basis for this program, is the premise. And the premise is that the conscious effort to change how one speaks or moves, that's why you see these like, make a big movement, to make these automatic tasks effortful, it really actually activates a different pathway in the central nervous system. So when people speak with intent, and it even happens when I'm evaluating someone, I'll have them read something and they read it a certain way. And then I'll give them a bit of a cue and I'll say, okay, well, let's use intent. And then I'll have them read it again. We didn't work together for 6 months. So they just really were able to cue into that intention and they sounded very different. And that's very important to know that the muscles, the Parkinson's doesn't attack the muscles. It's just that inactive use. So if you continue to speak at a very low volume, that's really what's going on with that breath support. So let's go to the next slide. So the Speak Out, which is the name of the speech therapy program, it usually consists of 12 individual sessions. They're about 40, 45 minutes long, which I love that they're not 60 minutes long because I feel like people kind of hit a wall. So it's very digestible. You move from exercise 1 to 2, 3, 4. And like I said, it's always 6 components. And during the speech therapy, the patient and the speech therapist work through speech, voice, and they always add a couple cognitive exercises at the end, okay, which I love. Daily home practice is very essential. Cynthia, yes, and singing is really part. Cynthia Stone is asking, does singing help? Singing is always helpful, and I'm going to show you a couple of videos at the end of this presentation of how singing is actually really incorporated into this protocol. The loud crowd, which is what I mentioned, after somebody graduates from doing their speech therapy, they graduate onto the loud crowd. And that's really to help keep that motivation up, that we're kind of like all in this together, trying to maintain our voices as long as humanly possible. Okay. Because circling back to what I mentioned before, you know, we think it's really an essential part of being a human being, your ability to communicate. Let's go to the next slide. I wanted to show some before and afters because it's quite, like, wow, very impressive how someone can go in and sound a certain way, sound very soft, sound very monotone, and then they do post-treatment videos. And these people just sound so great. They sound strong. They're like, my family's so happy. I can talk to everybody. I don't feel left out of conversations. So that's really why I wanted you all to see it. Obviously, if we can't get to it, I could possibly connect with Sharon when we're done and maybe, oh,
There we go.
Ashlyn's amazing. Okay, here we go.
Thank you very much.
Has anyone said anything to you about your voice?
Well, sometimes my daughter will say, clear your throat, or my husband will say, clear your throat.
I've noticed that I speak with clarity and I articulate better and I speak with intent.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. It's not loud enough. People don't understand. My daughters have all been very pleased, and they all said that I've got my old mum back.
I'm hoarse, and I don't have the energy to get the words out a lot of the time. I feel more confident when I speak. I'm not afraid to initiate the conversation, which before I probably would kind of say, oh, I don't need to speak unless I'm spoken to. I'm definitely more social. I don't even have to ask them. They tell me that they really can understand me better, and my voice is very clear, and they're amazed.
Thank you so much, Ashlyn. I wanted to, I'm so happy that you figured that out for us, because it's important to know that you don't have to wait till your voice sounds like some of the people you saw. There was one woman on that video that you saw, her voice is very impaired. And, you know, one of the things I always say is when you get that diagnosis, oh, here we go. When you get that diagnosis, you can go get a speech evaluation, even if you feel like nothing's going on. This, I really wanted to include this. This was something that the Parkinson's Voice Project, they talked about this teeth analogy and oral care. And I really want to share this with you because this really stuck in my therapeutic mind. And I always tell this to everyone I work with. We take care of our teeth. We brush and floss daily, hopefully, maybe. You go for cleanings, you go for checkups, and you get the cavities repaired, you get these fluoride treatments, and you're just trying to prevent major issues, right? And then you may say, okay, well, how are you taking care of your voice? And the answer that this person gave was, oh, my voice is fine. I'll call when I notice a problem. So the idea is that you understand that that's not the way to approach this, that the way to approach this is better aligned with oral care, that this is going to be a daily thing to take care of your voice. And the people I'm working with now that I have on this protocol, they'll say, you know, I noticed a difference when I didn't do my exercises. And I said, yeah, because you are now having to warm up your voice. You have to warm up your voice. You have to do your exercises. So you need to incorporate it into your daily routine. And when you see a change and when you hear a change and you start getting that feedback, then obviously there's that real great buy-in. But this program is very easy to follow and has great results. So let's go to the next page. Okay, so hopefully I haven't taken up too much of our time, my allotted time. These are the takeaways. If I leave you with anything, don't wait until your voice is severely impaired, okay? Early treatment is the best treatment. It's easier to maintain a voice than restore from my clinical perspective. The clinical side, it's way easier to maintain you than to restore. If you seek assistance and you think about that Hone-Yar scale, which is that scale, the continuum of Parkinson's, remember, I brought up my dear late patient who came to me and she was already at stage 5. We still got some voice out of her, which was wonderful for her family to hear, but a lot different if I would have met her earlier along in her journey. And I included this because I've been getting a lot of self-referrals. So advocate some more for yourself. Anyone can refer you to speech therapy who's a doctor. My latest patient, I have a referral from an ear, nose, and throat doctor down in Irvine. And then I have a lot of the great motor disorder doctors who are realizing I can't talk the talk that I'm treating holistically. I'm treating the whole person and I'm only referring to one thing, right? So communicating, eating, swallowing, these are huge parts of who we are. So try to get those referrals if you can. And now I think we can open up for questions.
Yeah, we have a few questions.
This is my info. If anyone would like to contact me, this is my information. You can give us a call. Obviously, you can email. And if you think of something like in a week, feel free to email me if something doesn't come up right now.
Okay. I have one quick question and then we'll open it, then I'll read the rest of them to you. So every once in a while I swallow around a couple of times a week. And I'm assuming that that is very common with most of this group. Is that enough of a reason to have my speech evaluated?
So every once in a while, swallowing wrong, and then what happens? Then you cough? Is that what you feel? Yeah. I would just start paying attention to what I'm having problems with. So so I'm always having problems with these liquids. So if it's always having problems with liquids and it's happening quite regularly, I do think it would be in your interest to say to your doctor, okay, so I had, obviously you run this blog and you have all these people present and you can say you had a speech therapist on, she was talking about dysphagia, because I'm very much a proponent of, we have these exams to literally say what's going on, but I don't want to scare you, because sometimes what we call penetrating, going into the laryngeal vestibule, which is above the vocal cords, which is different than aspirating it, going down the trachea into the lungs. Sometimes that's a normal part of the aging process. Okay. And so the way we look at it, can the host tolerate an aspiration event? I take a sip of this, I choke on it, I go, then I stand up, I go about my day, and I go get my steps in. I'm not immunocompromised, and my oral care, I'm on point. My mouth is clean. But I choke on this. I'm not getting up that much. My oral care is not great. I might be immunocompromised. So there are people who are more vulnerable to that, right? So if it's happening a little more frequently, I would want to know what's going on. But usually, if it happens chronically, you're going to start developing symptoms of possibly like a pneumonia, because the lungs don't want coffee and orange juice in there, right? But I'm thinking that you might be getting a little bit of what we call laryngeal penetration, and your body's kind of coughing it up, which is the protective mechanism that it should have. But if you have a supportive physician, they should never say no to you if you're seeking out advice, medical advice, or say, you know, do you think that this is warranted? You've managed to stay healthy in spite of these random moments, but if they become frequent, I definitely think you should ask your physician to give you an order.
Okay. All right, let's just go through. We have a few questions. Kim says her voice has gotten gravelly, and she was told by her speech therapist she needs to rest it, not force projection. It's plenty loud. What is your suggestion?
So you are seeing a speech therapist?
She is.
Yes, yeah, I am.
Are you doing a specific program for Parkinson's?
No, because we did that at the beginning. We started with the loud, but what was happening is I'm not sure of the terminology, but she said, I'm wearing my vocal cords out. Is that possible? And that she wanted me, to rest them as opposed to project them. And most of the programs you would project.
Right. So the only way she can tell if you've done anything is if she scopes you. So we did. So you were scoped by an ENT or your speech therapist?
No, by an ENT.
Okay. So you had edema? You had swelling?
No, there was no swelling. That's what he said. That's what was really weird. There was nothing that they could see in there that was causing any problem.
Okay, so I hear you now. You have a very strong voice. I hear a little groveliness in your quality. Right. And if I scoped you, because I do that as well, speech therapists scope as well, and so do the ENTs. If I scoped you and your anatomy looked fine, and you didn't have what we call erythema, that you were red, and you didn't have edema, which is swelling, and your anatomy was moving okay, I don't see a reason why you wouldn't be able to do these exercises. In fact, the groveliness is like a habituated place that voice goes, and doing the exercises gets you back to that smoother voice. So I have someone I'm working with right now that at the first 10 minutes of our session, she's in this, I'm going to try to do it. She's almost in this thing that we call glottal fry. So she sounds like this. Good morning. How are you?
I know that voice.
Then we do the warm-ups and she sounds like this. Did you hear the change? I started grovelly and then I got into that smoother, more ideal voice. Because
it's about using your diaphragm, if I understand correctly.
Using your diaphragm, and this is mechanically okay. If he or she, I don't know if you specified if you have a male or female ENT, if your ENT said that you were anatomically okay up here, okay, so that's what I usually want. If I think you have a nodule, or I think you have a polyp, or I think you have a cord out. So a lot of the cardiovascular surgeons, when they do heart surgery, there's a nerve, the vagus nerve, which is a very long nerve, wraps around the aorta, that controls the vocal cords. So when those cardiac surgeons move all that around,
Oh, wow.
people come out of those surgeries and they sound like this. Hello, how are you? Yeah, I'm fine. Because that cranial nerve was moved and tugged. So those cords aren't coming together. So you have that air between there. You can do this, right? You can go,
For quite a long time.
and you sound good. So I wouldn't tell you to rest your voice, because this isn't a diagnosis that you should kick back and sit on the couch and not do anything. As you all know, it will make you want to do that, right? Because the dopamine, it's hard to motivate. It's really hard to motivate, especially when you have Parkinson's.
Anyone who knows me knows I cannot not talk. I have to be able to talk.
I love that. I love that. But that's what I want you to be able to continue doing. So I definitely respectfully disagree.
Okay, that's what I wanted. I needed to hear your opinion.
I respectfully disagree. Give me a call. I respectfully disagree, because I don't want you not to talk. I would want you not to talk if you had something anatomically going on, but you already had an instrumental assessment that looked at your cords. So if you have that, then remember those 3 slides that the slide I put up with the lungs, the voice, the vocal cords, and the articulation, the articulators. The combination of all those 3 are what caused those changes, right? So if they looked at the cords, they looked at the anatomy and they said, you're good, then there should be no barriers on your ability to do a speech therapy based protocol. I mean, for Parkinson's.
Thank you very much.
You're welcome.
We're going to take Donna's question, and then I'm going to wrap up, and then we can go back to the questions in the chat. Okay.
This one is I don't know if it's connected with voice or not, but I have real shortness of breath. Like just getting undressed and brushing my teeth, I go over to the bed and I'm panting when I'm laying down in bed. And the Parkinson's doctor said it wasn't connected with Parkinson's, but I think it is. And you mentioned shortness of breath. So what do you think?
Well, I mentioned, I don't know if I used the word shortness of breath as much. I mentioned the decrease in the speech breath coordination. So I mentioned the ability to get through a sentence like I'm saying right now and running out of air because, the coordination. Okay. There are exercises to work on your capacity. Respiratory muscle strength training is something I do all the time with people, whether they have Parkinson's or they come to me because whether they have Parkinson's or come to me because they've had a stroke. Now, obviously you've talked to your physician about this, but in the context of speech, your breath, your breathing, your speech coordination is very much attached to the capacity, right? One of the exercises that we do is mean phonation time on an evaluation. And I'll say, and I know that who I was speaking to before, she kind of joked, she's like, I can do that for a long time. So check, how long can you do that? Can you do, or can you hold that for 15, 20 seconds? So all of that is, I don't know what's going on specifically with, why you're running out of air when you're getting up to go and brush your teeth. But in the context of speech, that's something we work on. So we're working on all of this together. And that's why, like I said, I really love that program out of Texas, because they don't ask for your money. They don't ask you to sign up for anything. They have this huge endowment, so they can send all the workbooks to all over the country. And they're even in like Australia, and they're trying to train every speech therapist under the sun in this. And I really like the purity of intention there, that they're not saying, you can learn our thing, but sign up, sign up. So there's evidence behind every exercise they've curated, right? So there's an exercise in that program that's flexibility with your voice. Because people can talk like this and there's no movement in that voice, and it's monotone, monopitch. And right. So they curated every single exercise. So yeah.
Okay. Kathy, is your question short? And we'll move on. You're muted. You're muted.
I had a pharyngeal flap back in 1984 because they thought I had an insufficient palate. And what they did find out is I actually had myasthenia gravis. So all my muscles were weak and everything. And then I had a surgery where they gave me plasmapheresis and I got my strength back. And it's went into 100% remission. Well, now I have Parkinson's and I have a flat back there. So, and then the newest thing is they're telling me I have a tongue tie. So I should get a tongue tie release.
Interesting. So you had the IVIG treatment for myasthenia gravis completely resolved.
Uh-huh.
Then when did you get your Parkinson's diagnosis?
In 13, but I probably had it 5 years prior.
And do you have trouble swallowing?
Sometimes, but I really learned when I had the myasthenia how to not choke, because I did about choke when I had that.
Right. So you're managing swallowing, and you obviously have a great, strong voice. You're totally intelligible to me. I'm an unfamiliar listener. So
Yeah.
you're doing okay
Sometimes
in those two
people
areas.
say I'm quiet when I talk, but I don't get that a lot.
So it's kind of going back to the
Can
whole,
I ask that we talk about, do this after, because this
Okay.
it takes more time. So we'll stay on afterwards for a few minutes. Just a couple more quick questions. Cynthia just walked out of the room. I hope she hears this. She says, what do you do if you're taking large pills that can't be cut? And does singing help? And then Joan Swirsky asked about her insurance covers only LSVT loud, not speak out. But you said that they're covered by an endowment. So that's pretty much it in the questions. And I think, can we hold those for 2 minutes, and then those who want to get off can get off? All right. So let's go to Ashley. Let's just do the last few slides. And then if you want to have more questions, we'll stay on. So Patricia, we're sending you a virtual tiara because I can't give you one in person, but I have mine. It's for you.
Oh, thank you.
Thank you. This is wonderful. Next slide. And our peer-to-peer mentoring program is really working well. If you are newly diagnosed and looking for someone to talk to, you can ask to get a mentor through our program. Or if you've had Parkinson's for several years and want to help someone else learn to live with Parkinson's, we would love to have you as a mentor. Here I'm running out of breath. And for those who are current mentors, we have a meeting on March 1st at 4 o'clock Eastern time, 1 p.m. Pacific time, and we really need to hear from you whether or not you can continue mentoring in the program. And if you are going to continue, we need you to attend that meeting. All the information is on my website. I will put we'll put something on the weekly newsletter tomorrow about the program if you're interested in signing up to be a mentor or mentee. Next slide. Our scholarships. We've got 12 people, I believe, and we are finished with that. We have one person from Iceland and another person, I think, from Australia, which is really exciting. We have people from all over. Next slide. If you are going to the World Parkinson's Congress and you haven't told me, please let me know, and I will invite you to join our private Facebook group. You can list Twitchy Woman as your official organization when you register, and we hope to have some kind of get together when we're all together in Barcelona. And the next slide. Coming up in 2 weeks, if you want to sing, work on your voice, join us in 2 weeks with Judy Spencer, and she talks about the World Parkinson's Choir, who will be singing in Barcelona, but you can attend I believe you can attend the rehearsals all along, even if you're not going. So if you like to sing, join us in 2 weeks. March 12th, Dr. Peter Tass will be talking about vibrating gloves for Parkinson's, and it will be our 3rd anniversary celebration. And if you want to help plan the 3rd anniversary, please let me know. March 26th, we're going to be doing some exercises with our polls. If you don't have polls, it's okay. You can still join us. And April 16th, Kenneth Thurman will be talking about the Aware and Care Kits from the Parkinson's Foundation. And if you're not aware of the Aware and Care kits, they're great to have when you travel. They're really designed for when you go to the hospital and you put all your meds in there, and there's explanation about Parkinson's and everything that you need to know. And we are actually booked through the end of May, but I'm not going to give you all of the details because there's just too much going on. Next slide. And just a reminder, we have our Anything Goes on Tuesday mornings with Shelley Savoy. And then on Sunday mornings before our regular meetings, we have Twitchies Without Partners. And right now we're starting to work on a toolkit for Twitchies Without Partners. What do you need in your toolkit? Who do you need to have in your kit? So speech therapy obviously could be one of those things. And I believe that's it.